Hello, I'm Dr. ANUSREE, Senior Lecturer, Department of Conservative Dentistry and Endodontics. I'm here to discuss about management of calcified canals. What is calcific metamorphosis? According to American Association of Endodontists, calcific metamorphosis can be defined as a pulpal response to trauma characterized by rapid deposition of hard tissue within the canal space. This is also known as diffuse calcification or calcific degeneration. Up to 25% of the traumatized anterior teeth can develop canal obliteration, and up to 75% of the teeth with pulp canal obliteration are symptom free and require no treatment other than radiographic monitoring. Coming to clinical features, as we can see from the picture, discoloration is the most common clinical finding, and the exact mechanism of canal obliteration is not known but is believed to be due to damage to the neurovascular supply at the time of pulp, at the time of injury. Routine pulse sensibility tests are unreliable in the presence of pulp canal obliteration, and radiographic features include partial or complete calcification of the pulp with or without periapical pathology. You can see here in the radiograph that there is complete calcification of the pulp with no periapical pathology. Coming to causes, calcific metamorphosis can be caused due to trauma, caries, placement of restorations, vital pulp therapy procedures, orthodontic treatment, aging, or due to systemic intake of statins. Calcific metamorphosis can be classified into partial or total obliteration, and according to Cronfeld and Boyle, it can be classified into diffuse or linear calcification and pulpstone or tentacles. Coming to management of calcified canals, according to literature, around 1 to 16% of the teeth with calcified canals are found to develop pulpal pathology. So, the choice of treatment depends on periapical status and canal patency of the affected teeth. Various treatment approaches include wait and watch, non-surgical approach, surgical approach, non-surgical followed by surgical approach. First, we will discuss about non-surgical approach. Before SS opening, the distance from the occlusal surface to the pulp chamber can be measured from the radiograph. And we have something called pulp out burrs. These are friction grip burrs with a round carbide burr and a plastic stopper fixed at 7 mm from the tip. This length has been determined to be a critical depth from the cusp to the pulp chamber that allows access to the pulp chamber without perforation of the furcation area. Now, how to locate the calcified canals? First, we have to inspect for any color change that may indicate way to the orifice of the root canal. We can use dyes such as 1% methylene blue to assist in locating the orifice of the canal. Champagne bubble test. As we can see from the picture, when sodium hypochlorite is allowed to remain in the pulp chamber after SS opening, appearance of bubbles frothing from a point in the floor indicates presence of root canal orifice. Magnification and transillumination using fiber optic light can be used to detect the canal orifice. Piezoelectric ultrasonic unit can be used, and we have instruments such as micro openers and explorers such as DG16 and JW17. We can use tests such as white line test and red line test to detect the canal orifice. And burrs such as Mueller burrs, Mune's discovery burrs, endoguide burrs, and number 2 round burr can be used. Pathfinding instruments such as Pathfinder CS, C plus files, K file with modified tips, that is, tip of the K file is cut diagonally to make it thinner, and this will increase the penetration potential of the file. Smaller K files such as 8 and 10K file can be used to negotiate the canal. Coming to biomechanical preparation, it is usually done in a ground down fashion, and chelators such as 17% EDTA can be used as adjunct during biomechanical preparation. Pips and sweeps can be used to improve irrigation, and obturation can be done by vertical compaction, lateral condensation, and continuous wave technique. Surgical approach should be considered only in cases where non-surgical treatment or retreatment has persistence of periapical disease or symptoms. Root and recession followed by filling should be considered when canal cannot be located. So, perforation, loss of tooth structure, failure to locate the canal, and long treatment time with multiple visits are the difficulties associated with treatment of calcified canals. To overcome these difficulties, we have something called CAD/CAM navigation system. A computer-designed 3D printed guides are used to gain guided access during root canal treatment. This includes static and dynamic navigation. To discuss about static and dynamic navigation, we require more time, so we will discuss about this topic in detail in a later session. Thank you.